Good morning, everyone. This is the 4th of October 2022. It is an eventful day because this is the birthday of my dear granddaughter Anushka. Anushka turns 2 years today, and therefore a very, very happy birthday to Anushka. And also I wish her the best in her life and that she has a spectacular life ahead of her. I take this opportunity to discuss the great trial which has been published around 10 days ago in the New England Journal of Medicine. This is a trial on patients with diabetes. Now, diabetes has a massive footprint in India. There is a huge burden. In 2019, there were around 77 million people with diabetes in India. 90 to 95% of them were type 2 diabetes. And we have data on the prevalence in different states. Chandigarh has the highest prevalence with 13.6%. Tamil Nadu comes second with 10.4%. Punjab has a prevalence of 10%. Where these cities were concerned, Delhi has a very high prevalence of 26%, and Chennai has a prevalence of 22%. So you clearly see that there is a very large number of people suffering from diabetes in this country. Now, diabetes has massive complications. These could be divided into microvascular complications and macrovascular complications. The macrovascular complications are heart attacks, strokes, and heart failure. The microvascular complications are retinopathy, nephropathy, neuropathy, which means that a person, if he has retinopathy, can develop blindness. If the person has nephropathy, then the person can develop kidney failure. And if there is neuropathy, then the person has loss of sensation, which leads to amputation in the future. As far as the macrovascular complications are concerned, these could be, as I've just said, heart attacks, strokes, and heart failure. Now, we have data. We have randomized data in thousands of patients, which tell us that there are two classes of drugs which are effective in preventing macrovascular cardiovascular complications in patients with diabetes. These two classes are an SGLT2 inhibitor. I have already spoken about this class of drug in my videos on heart failure. And also, we have what are known as GLP receptor analogs, that is a liraglutide or semaglutide. These are injections, and which also, apart from controlling diabetes, also prevent atherosclerotic diseases. Now, there is a gap in how to treat a diabetic which is of recent onset, which means that the diabetes has developed in the last 5 or 10 years. We all know, based on the UK PDS study, that Metformin is the first drug of choice. So between you and me, by and large, one would begin treating a patient with diabetes with Metformin. It is a cheap drug. It is given orally. It can be given once a day or twice a day. A single tablet of about 1,000 milligrams of Metformin in India costs just about 3 rupees. So there you have a cost of just 3 rupees a day in treating initial diabetes. Now, apart from Metformin, which is a biguanide, which sensitizes the body to the effect of insulin, the second drug is still unclear. What do we introduce once we've introduced Metformin in a person with low risk for cardiovascular complications or who has not developed established cardiovascular disease? What is the second drug? So the GREAT trial, which is published in the New England Journal of Medicine, provides us some data. This compares 4 classes of drugs. The first is a long-acting insulin, that is insulin glargine. And then we have a GLP receptor analog, which is liraglutide. We have a sulfonylurea, which is glimepiride. And we have a DPP4 inhibitor, which is sitagliptin. This trial included more than 4,040 patients with diabetes. The mean age was about 57 years. Around 63% were males and around 65% were white Caucasians. Only 3 to 4% were Asians, which means that, strictly speaking, we cannot extrapolate data from this study. However, this is the best we have right now. These patients were followed for a mean of 5 years, and what was found was all 4 anti-diabetic drugs were almost more or less equally effective in controlling the glycated hemoglobin, which tells us the level of glucose in the previous 3 months. Now, the important thing is that between these 4 drugs, 2 drugs were slightly more effective in controlling the glycated hemoglobin, and these were insulin glargine, which is begun at a dose of 20 units per day and gradually built up, and liraglutide, which is the GLP receptor analog. Now, these 2 drugs were able to reduce the glycated hemoglobin more than the other 2 drugs, that is glimepiride, the sulfonylurea, and the DPP4 inhibitor, which was sitagliptin, which is called Januvia in India. Now, this is very important because if you have to begin a second drug, then I would use these. Of these two, I would use, the second drug which I would use would be either an insulin or it would be a GLP receptor analog. The problem is that both are injections. Now, apart from this, there was hypoglycemia. Hypoglycemia was maximum with the glimepiride at about 2.2%. Insulin glargine caused hypoglycemia in about 1.3%. Liraglutide caused hypoglycemia in 1%. Sitagliptin predictably produced hypoglycemia in just about 0.7%, which means again that sitagliptin is a weaker drug. It is the weakest of these four drugs. However, one must bear in mind that when this study was begun, the SGLT2 inhibitors had yet not been approved by the FDA, and therefore that class of drug was not included in this study. So as far as I'm concerned, if I was to begin treating a patient with diabetes who has developed diabetes in the last 10 years and would be considered a low risk for a cardiovascular complication, I would begin with metformin, or in fact I would begin with an SGLT2 inhibitor, or I would begin with a metformin and add an SGLT2 inhibitor, because an SGLT2 inhibitor is known by randomized trials not only to prevent heart failure, but if heart failure has developed, it is also known to reduce mortality or hospitalizations following heart failure. Now, apart from this, in the GREAT trial, there was a suggestion that liraglutide, which is a GLP receptor analog, reduced cardiovascular complications by about 29% as opposed to the other three drugs. Apart from this, the microvascular complications were more or less the same by these four drugs. So what is the take-home message? The take-home message is that if you have a patient of diabetes, the common sense approach would be to begin treatment with metformin, and once metformin is found not to be effective in controlling the glycated hemoglobin, it would be safe to add an SGLT2 inhibitor, or as per the GREAT trial, a long-acting insulin such as insulin glargine or a GLP receptor analog. With this, I end this video, and once again, a very, very happy birthday to Anushka Baba. Thank you very much for watching this video.